case 3 is a patient with shortness of breath and joint and back pain. A 25-year-old man claiming to have a history of sickle cell anemia comes to the emergency department with an acute onset of severe knee and back pain, typical of his vaso-occlusive crisis in the past. In addition, over the last few hours, he's had the acute onset of pleuritic pain, severe shortness of breath, and fever. He typically suffers from crises every 3 months. So this is a case we all have seen either in the emergency room or in the inpatient setting or in the clinic sometimes. But some people have severe sickle cell disease and need to come with vaso-occlusive and pain crisis to the emergency room in the hospital frequently. This guy every 3 months. Let's go further and look at his vital signs. He appears to be in acute distress. His temperature is 101, so he's got low-grade temperature. Blood pressure 180 over 100. This is elevated, but this guy is in pain, so you assume that this is likely from the pain. His pulse is elevated at 120 per minute. His respiratory rate is definitely elevated at 30 per minute. The physical exam shows tachycardia with a 1/6 systolic murmur at the left lower sternal border. So sometimes with anemias you could get a flow murmur, and maybe that's what this patient has. There's no CVA tenderness. The remainder of the physical examination is unremarkable. So what do we think about this patient? Well, the differential diagnosis here is short. This patient either has a vaso-occlusive crisis of sickle cell disease, which is what they really present with, or the patient has something along with the vaso-occlusive crisis, like some kind of infection, like a pulmonary infection or some kind of other infection. Remember, infections are common precipitants of sickle cell crisis. So you should say this is vaso-occlusive crisis, secondary to what? Well, sometimes it's just stress, exposure to cold, exercise, but sometimes it's an infection, and especially in this patient with shortness of breath, you have to think about pulmonary infection. So here, the differential diagnosis 1 and 3 could be going on at the same time. We always have to say sickle cell crisis precipitated by what? Sometimes it's nothing important, but sometimes it's an infection and you have to look for it, especially in people with shortness of breath as this patient. You have to look for some kind of pneumonia. Remember especially that sickle cell patients are prone to infections from encapsulated organisms. When they get encapsulated organisms, it's devastating for them. A lot of them don't make it when they get these kind of infections, so you have to be careful. We didn't get any history that this patient has been immunized for strep pneumo, so you got to worry about this. You also have to think about that along with the vaso-occlusive crisis, we see hemolytic crisis at the same time in a lot of these patients. That's why the hemoglobin drops and you get a little bit of icterus in this patient, so you should look for that. Now, pulmonary infarction or acute chest syndrome is really, it's part of the vaso-occlusive crisis. The reason why we kind of put it on its own because it's managed a little bit differently, and you really have to watch the patient closely. What the acute chest syndrome is that you have vaso-occlusive crisis, sickling, and infarction in the small vessels in the lung. And this could look just like a pneumonia, especially in a typical pneumonia on the chest x-ray. And these patients, just like this patient, present with shortness of breath and chest pain and pleuritic chest pain. And the reason why we make a big deal out of it is because these patients, sometimes you need an extra level of treatment. For example, if they don't get better, you start to think about doing exchange transfusions in these patients. That's why you need to diagnose it. Also, be careful when you see an x-ray that shows fluffy infiltrates or interstitial densities in a patient with sickle cell disease. Be careful. That could be a pulmonary infection and you have to treat it as one until proven otherwise, but it could also be this acute chest syndrome. So if the patient doesn't get better on antibiotics 2-3 days later, think that this is pulmonary infarction or what is called acute chest syndrome. Please remember that. They test that sometimes. So that's our differential diagnosis. We shouldn't think about other types of crisis here. Be careful. There are other types of crisis in sickle cell disease, right? There's the aplastic crisis that some patients get with parvovirus B19 infection. It's rare, but we don't have any evidence of that here until now. It doesn't tell us anything about recent infection or anything like that. And then there's the crisis that little kids get with sickle cell disease. Little kids, adults don't get this, which are called sequestration crises. Sequestration crisis, remember you have to have a spleen to get a sequestration crisis. We don't see that in adults because the spleen has autoinfarcted. So little kids presenting with sickle cell crisis, and they tell you sometimes abdominal discomfort, and you do an exam in the abdomen and you feel this organ on the left side that's engorged. This patient has sequestration crisis. This is a medical emergency. So please be careful of that. But we shouldn't think about anything like that here. This is an adult, not going to get sequestration crisis, likely doesn't have a plastic crisis either because we have no evidence of that on exam or from the history. So where do we go from here? Our initial diagnostic plan is to confirm that what this patient has and look at the severity of the anemia and the hemolysis, and this is what we get. The WBC count is 14,500. Now this is interesting. People with sickle cell crisis, just from the pain and the crisis, could get leukocytosis. But this leukocytosis needs to be looked at very closely because this could also mean that the patient has some kind of infection. Sometimes the infection is subclinical, so please be careful. Remember that infections precipitate sickle cell disease, so look for that. They're going to test that concept if they give you this patient, that you look for infections. So I'm worried about this 14,500. It could be part of the sickle cell crisis, but it could be part of infection, and I'm going to look for it. So the hematocrit is 25%. It's low. So the hemoglobin is probably 8.5 or something like that. The platelets are 480,000. The reticulocytes are 15%. That's elevated. That's what happens with when patients hemolyze. So please make sure you look at the reticulocytes when a patient comes in with sickle cell disease. Make sure they're elevated because if they're not elevated, then you worry about some kind of plastic crisis. You always got to worry about that. The peripheral smear shows sickle cell present. The bilirubin is elevated, 2.3, 85% is unconjugated. So this is a typical sickle cell crisis so far. Where do we go from here? Well, I want to see the level of hypoxemia that this patient has. I want to look at cultures. I want to look at a urinalysis to make sure the patient doesn't have some kind of simple infection like a urinary tract infection. And I want to look at the chest x-ray to make sure that the patient doesn't have some kind of infiltrates that warrant further evaluation for infection or a treatment with antibiotics. So here are the results here. The urine analysis shows hematuria, no white cells, so that's good. The arterial blood gases show an ABG of 7.5, right? This is alkalosis. The CO2 is decreased, 32, so the patient has a respiratory alkalosis. This is consistent with the shortness of breath that this patient has. The chest x-ray shows a focal infiltrate peripherally on the right and fish mouth vertebrae, right? Some of the patients with sickle cell disease have this on this bone involvement that's due to the sickling process. But that focal infiltrate here is very disturbing. This could be an infection like strep pneumo or Haemophilus influenza, and you really need to act on this right away. Make sure you cover organisms like that because this patient could get a fulminant infection, or this could be part of the chest syndrome, right? The pulmonary infarction, acute chest syndrome. So, but the bottom line is I have to treat the patient with antibiotics probably until I get everything together, until my blood cultures come back negative and stuff like that. So the blood cultures here came back negative. The sputum culture is probably an overkill. Probably the gram stain in the sputum would probably be more effective in this patient. The hemoglobin electrophoresis, you don't need to get this in the acute setting. I'll tell you for teaching purposes, we put this in here to show you a couple things here that are very important. You would get this mostly in the outpatient setting, confirming that this patient really has sickle cell crisis, sickle cell disease, because some of the patients, believe it or not, think they have sickle cell disease, but they have sickle thal trait. They could have both. So there's other variants of sickle cell disease that you need to confirm, and also for genetic purposes you need to confirm this. So the sputum culture is negative. The hemoglobin electrophoresis, you could see that hemoglobin S is 86%. The fetal hemoglobin is 12%. Now here's what you need to know for the boards right here. Hemoglobin A right here is 0. Hemoglobin A in all patients with sickle cell disease, not sickle trait, is 0. Remember, all the hemoglobin A has turned to hemoglobin S, is overtaken by hemoglobin S. So please remember that. They've asked questions on that. If a patient had sickle trait, they would have hemoglobin S plus hemoglobin A. So if a patient has hemoglobin A of any percent, 2%, 5%, any percent, they don't have sickle cell disease. They have sickle trait, or they have a sickle and something else. They don't have sickle cell disease, purely sickle cell disease. Please remember that. So what's our treatment plan? Aggressive pain management with narcotic analgesics. And they've asked a question, what is the most important analgesic to use in people with sickle cell disease and sickle crisis? The answer here is morphine. Morphine has been shown to be the most effective pain drug in terms of pain management in sickle cell patients. Not short-acting drugs like Demerol and stuff like that, but morphine. So please use morphine unless it's contraindicated. Then, along with the pain medication, you have to give the patient a lot of fluids. Remember, a lot of these patients are dehydrated. Give them a lot of fluids. Give them oxygen therapy. This probably helps. It hasn't been substantiated in studies that oxygen makes a difference, but it's not a bad thing. This patient especially is short of breath. So you got to give it to them. And they have respiratory alkalosis and hypoxemia, so you have to give them that. So the triad of all patients with sickle cell crisis get aggressive pain management with morphine, hydration, a lot of fluids, 0.9 normal saline, start with that, and then oxygen therapy at the same time. This patient had an infiltrate on the x-ray, right? So I have to think that this is an infection. So I'm going to cover encapsulated organisms. I got to give this patient ceftriaxone or some other type of cephalosporin, right? Because this patient had fever and leukocytosis. Be careful. Don't assume the infiltrates are due to chest syndrome unless this patient doesn't get better a couple of days later. You're going to err on the side of an infection in this person. If the hypoxia doesn't get better and doesn't correct, and then 2-3 days later the patient continues to not be well, then you may consider number 5 here, exchange transfusions. Exchange transfusions are given in 2 scenarios. The chest syndrome, that's one, when the patient doesn't get better, or if a patient has severe crisis and doesn't get better 2-3 days later, you consider doing exchange transfusions. Be careful. Exchange transfusions is not just transfusion. Exchange transfusion is I take out blood from the patient and I give them supposedly normal blood. In the chronic setting, they've asked, what could you do to decrease this patient's frequency of crises? And the magic drug here is hydroxyurea. Hydroxyurea has been evaluated in different studies and has been really like a miracle drug because it decreases the amount of crisis that these patients get. Keeps them home. They don't have to come to the hospital. So it's a wonderful, wonderful drug to use in people with moderate to severe sickle cell disease. Remember, most people don't have severe disease. Those people, you don't have to consider it. but hydroxyurea in the moderate to severe form, you have to use it because it'll save them a lot of hospitalizations and a lot of evaluation in the emergency rooms. In the long-term setting, every patient has to get the pneumococcal vaccine. Every patient. When do you give it to them? You give it to them as soon as possible. As soon as you diagnose sickle cell disease, if you diagnose it in children, you give it to them right away because it's actually better. They have a spleen at the time, and they have a better immune response. But if you get an adult like this guy and you find out that they never gave him the pneumococcal vaccine because people forgot or something like that, they could still get it as adults, and it's still effective. And what do? Because this is a serious infection, these patients get serious infections, and you want the pneumococcal vaccine to be 100% effective, you give them a booster response 5 years later. So in most people, we don't have to do that. In everyday people, we don't have to do that, but serious diseases like sickle cell disease that are prone to encapsulated organisms, you give them a booster response 5 years later. So give them the pneumococcal vaccine and then repeat it 5 years later. These patients also should get chronic folate supplementation in their regimen every day, a little bit of folate every day, because they have, they're sickling every day. So it's good to give them folate every day as part of their vitamins that they get every day. This concludes case 3.